questions or anything, then just message and someone will let me know, I'm sure. Oh, I'm just trying to change slide. Oh, gone. So today we're going to cover ACS. We're going to mainly focus on this because that's quite a big topic. And then we're also going to cover heart failure, pericarditis, tamponade, constricted pericarditis, and aortic dissection. So I'm going to try and do it in like little cases. Hopefully that'll work. And if you guys can kind of join in and answer when possible, then that'd be great. So our first case is 60-year-old gentleman Steve, who's presenting to A&E with a 4-hour history of crushing central chest pain radiating to his left shoulder. So you probably have some ideas of what this might be, kind of cheating based on the cub. What are the differentials that we're thinking of?
People are saying MI, ACS.
Okay, perfect. Oh, I've got the chat up now so I can see it. So hopefully that worked. So it's not letting me change slide. Sorry, one sec. Oh, they will come up. So yeah. So first we're thinking of ACS, which would include MI, NSTEMI, and STEMI, and unstable angina. And then also thinking of pericarditis, aortic dissection, and it's important to think of other ones as well, like panic attacks and gastritis, which can all present similarly, but of course, most likely it's going to be ACS. So your triage nurse has kindly done an ECG for you. What do people think about this ECG? I can see the chat, so if anyone wants to pop anything in the chat, that'd be great. Yeah, ST elevation, and which leads can people see ST elevation in? Oh, yeah, perfect. So someone said anterior lateral STEMI, so that's really good. So if we can move through the slides, then you can see there's ST elevation in V1, V2, V3, and V4 mainly, but then you can also see some ST elevation in 1 and AVL on the other side. And we can see some reciprocal changes in leads 2 and 3, as well as AVF. And does anyone know what artery this is likely to be in? Yeah, so in our LAD, in the left anterior descending. Sorry, I think there's a problem with me changing slides. So I think it's as people enter the waiting, not letting me change slides. But I'm sure they'll cut in a second. Okay, so yeah, so this type of ST elevation is called tombstoning because of its shape, and that's not a good sign for the patient, unfortunately. So we can see ST elevation there, and then the reciprocal changes here, which is what you'd expect. And this is a graph that I'm sure you've all seen before, but it basically just shows the different regions and the arteries affected. There's not much you can do other than just learn it, really, unfortunately. So this was, as someone rightly said, a STEMI because there's ST elevation, and we'd also expect the biomarkers to be elevated. In an NSTEMI, then we'd expect the biomarkers to be elevated, but the ECG changes aren't specific, so you can get depression, you can get T-wave inversion, or it may be normal. And an unstable angina, the biomarkers would expect to be normal, so that's how you differentiate between them. Okay, so I've split the investigations up into bedside bloods, imaging, and special tests. We've already done one of the bedside investigations. We've done the ECG. And what do you think is the most important blood test to do?
Troponin.
Yeah, perfect. So the troponin, a full blood count as well is important, because severe anemia from a low so you see that with a low hemoglobin could be a cause of a type MI, which is poor oxygenation to the rather than from a blockage. And it's also important to do these because that shows LACES, which could make the heart have an arrhythmia. A chest X-ray is just something basically every patient in A&E gets, and it's important to look for other pathology around that area. Special tests. Does anyone know what specific test we'd probably do for an MI? So we do a coronary angiogram. That's right, someone said that, Lloyd. Which is the most specific test to see where the blockage is, and you'd have to do that before doing your management. So poor Steve, he's not in a great situation. And we're just going to go a bit back to basics and talk about risk factors for ACS, just because it's really good to have refreshed before OSCEs. So what are some non-modifiable risk factors that Steve has or could have? Yeah, so age over 65, male, family history, genetics, yeah, and also early menopause, although that might not be Steve's problem, but we can't assume. And then modifiable risk factors, so that's where the obesity would come in, would be smoking. Diabetes is very important and can also cause patients to have less typical MIs, so they get less obvious clear-cut symptoms, so it's important to watch out for them as they might be missed and they're not treated as well. Let's get there. Okay. Oh, what's happening? So yeah, obesity, hypertension, sedentary lifestyle, and recreational drugs such as cocaine can be a cause of MI, particularly in young males. You can see that sometimes. So how are you going to help Steve now he's in this situation? What is the immediate management of an MI? Aspirin. Yeah, so that's part of it. Okay, yeah, so you'd assess them using the AT technique. Yeah, someone said it, MONA. So what does the M stand for in MONA? Yeah, so morphine. And with morphine, we like to give an antiemetic because it makes people feel quite sick. So you'd also give metoclopramide normally. And then the O is for oxygen, but we'd only give oxygen if we're below 94%, aiming for SATs 94 to 98%, because they've shown that high oxygen can actually worsen some of the MIs. We'd also give nitrates, so GTN spray, and that should help with the pain as well. And we'd give dual antiplatelets, so that was aspirin, as someone mentioned, 300 milligrams, and also clopidogrel normally. There are a few different guidelines for different antiplatelets to give, but clopidogrel is often a safe one in most circumstances. And this is from the NICE Guidelines 2020. And then what you're going to do after you've done your immediate management. So Steve's stable. What is anyone thinking we might do next with Steve? If we're in the Royal and there's lots of ambulances who can transfer Steve for you, yeah. So you're going to send him to Liverpool Heart and Chest for PCI. Yeah, so if you can get to PCI within 20 minutes and and the symptom onset is within 12 hours, then that's the best thing to do for Steve. But sometimes there are other situations. So if you're on the Isle of Man in the middle of the storm and no helicopters can take off and they can't do PCI there, what is the best treatment option for Steve? Yeah, so thrombolyze. So we'd thrombolyze, or, and does anyone know what we'd use to thrombolyze? So you can use streptokinase or IV alteplase. And that is actually a tissue plasminogen activator. So it activates plasminogen, which breaks down fibrin and fibrinogen. So it basically just busts the clot. And we'd also probably give anticoagulation through unfractionated heparin. And one thing to say about thrombolysis in particular is there's some contraindications. So if they've had a stroke within the last few months or recent surgery, or if they've got brain cancer, then they might not be suitable for thrombolysis. Okay, so this was for a STEMI. The immediate management of an NSTEMI is exactly the same as for a STEMI. But then we use what's called the GRACE score to stratify them. So basically, the GRACE score looks at the 6-month mortality. It takes a lot of factors into account, such as age, heart rate, blood pressure, cardiac enzymes, and ECG. And you classify them into high risk, intermediate risk, or low risk. So if someone's clinically unstable, you're going to give them PCI straight away, just as the same as you would with a STEMI. If they're intermediate high risk, you're going to do PCI within 72 hours. And if they're low risk, you're just going to put them on a second antiplatelet and give them an anticoagulant, like Fundoparanex, to and probably send them home and then bring them in later for a further investigation. So secondary prevention. Lifestyle is really important, and it's easy marks in an OSCE, so it's always good to mention that. And does anyone know any medications we might use as well in the secondary prevention after MI? Also, someone's got an acronym SCARB. I don't think I've used that one, but yeah, so statin. Yeah, so there's different ones. Some people use them for so ACE. So we're going to use aspirin 75 milligrams once a day for life. We're going to give ACE inhibitors such as ramipril and a statin such as atorvastatin, and the dose would be 80 milligrams because it's secondary prevention. We're also going to give a beta blocker such as bisoprolol and a second antiplatelet such as clopidogrel, or whichever one you started in the A&E, and you're going to give that one for another year. And then you're going to give cardiac rehabilitation, which is another really good thing to say in OSCEs to give you extra marks. And that's just kind of a program of exercise and stuff to get people back on their feet after an MI. Okay, so we've done all we can to try and help out Steve, but unfortunately there are some post-MI complications that people can get. So does anyone know, this is a mnemonic that people might find helpful. You might be sick of mnemonics, but this is Darth Vader. Does anyone know what the D might stand for? So it could be Dresses. That's the one down there actually. So you've got that one already. But D is actually death. So obviously some people might die from an MI. The A stands for arrhythmia, such as ventricular tachycardia. So that's a common cause of the death after an MI. The R stands for rupture. So you can get rupture of the free wall of the ventricle, rupture of the papillary muscles, and rupture of the intraventricular septum. Rupture of the free wall leads to tamponade. Does anyone know what the H might stand for? This is a bit of a longer term complication of an MI. Yeah, perfect. And the V? So this is valve disease. So you might have mitral regurg from rupture of the papillary muscles. A is for aneurysm of the ventricle. I don't think you need to know too much about that. It's just ballooning of the ventricle that will inhibit blood flow. Someone already said the other D is for Dressler's syndrome. The E is for embolism. So it's important if people are immobilized, they might get clots such as PE and DVT as well. And R, the other R is for reoccurrence. So they might have a second MI, which is actually quite common for people to have more than one. So we've done all we can with our secondary prevention, but unfortunately, Steve presents 5 times with different post-MI complications. So these are some of the examples of the ones on the previous slide, if people want to have a quick last look. So the first one on the top left, so Steve returns to A&E in 5 days after collapsing and is severely breathless. On auscultation, you hear a pansystolic murmur. These are quite hard. And whoever asks, will I get this lecture? Yeah, you'll get the lecture, so don't worry about writing things down or anything. So does anyone know what this top left might be? These are very tricky. Oh yeah, perfect. So VSD, a ventricular septal defect leading to acute heart failure. So the pansystolic murmur is from the defect in the ventricles, and that's what you'd hear. And that's going to require emergency surgery. Don't think we'll need to know too much about that. Mitral regurg presents very similarly, but it's an early to mid systolic murmur. But that is also a really good guess, guys, don't worry. So poor Steve, unfortunately, 2 weeks later, he's back in A&E after collapsing. You notice he has an extremely elevated JVP, but you struggle to hear any heart sounds. Does anyone know what this might be? Yeah, so this patient has cardiac tamponade, and that's often from the rupture of the ventricular free wall, so blood's oozing out from the ventricle into the space around, causing cardiac tamponade and acute heart failure. And we'll be looking a little bit more into cardiac tamponade later. This is another one. 3 weeks later, Steve presents feeling hot and breathless, with pain worse when he breathes in or lies down. Yeah, so that's Dressler syndrome, which is the type of pericarditis, which we'll talk a bit more about later. It's autoimmune, and it normally occurs a few weeks after an MI. People aren't quite sure why, but yeah, that's normally a couple of weeks later, whereas you can get acute pericarditis just after an MI as well. And finally, Steve presents a couple of months later with increasing shortness of breath and fatigue and swelling around his ankles. Does anyone know what this one might be? Heart failure, perfect. Yeah. Well done to everyone who got them, because I think it's quite tricky to think quickly as you're going. And let's move on. There we go. Okay, so next we have Bob. He's had heart problems for a long time, but recently he's breathless all the time to the point he can hardly get out of bed. His legs are very swollen, so Betty's persuaded him to come into A&E. Though I hope they rang their GP first. Does anyone have any idea what might be going on with Bob? Yeah, so this is heart failure. So he's probably had chronic heart failure, which has decompensated. So that's our top diff. Does anyone have any other differentials? So it's good to be able to think of some other options. Yep, so PE, particularly with the swollen calves. Maybe he's got bilateral DVTs, you never know. I'll go back a slide, but I also can't go forward a slide, so it's a bit challenging. Okay, here we go. So yeah, sorry. It could also be ACS, an exacerbation of COPD, pneumonia, any type of failure really, such as renal failure and pulmonary embolism. And whoever said MI leading heart failure is really good as well, because a lot of acute heart failures are caused by so investigation findings. So first we're you know, Bob's quite unwell, so he's going to be assessed using the A to E approach. So for A, we're just going to be looking at his airway, and his airway is his own. So that would cover A. And does anyone know what we might look at for B? Yeah, so we're going to be looking at his rest rate. He's likely going to be tachypneic, breathing fast. We're going to be looking at his SATs. Unfortunately, Bob's SATs are low. He's short of breath visibly, and there's bibasal crackles at the bottom of his lungs. We're going to do an ABG, like someone said, and we're going to find type 1 respiratory failure, so a normal CO2 but a low O2. We're going to order a chest x-ray, an urgent chest x-ray, to come as soon as we can. We'll probably give him some oxygen because his SATs are low. So because we're in an emergency, we're going to be doing 15 litres through a non-rebreathe mask. And then we're going to move on to C. So he's tachycardic because everything's going on. He's got peripheral edema, and we're going to take bloods. Does anyone...
I don't think the screen's moved on. It's still on the differentials and investigations.
Oh, sorry.
Okay.
Oh, there's one. There we go. Sorry about that, guys. Yeah, so we've got his bibasal crackles, ABG, and chest x-ray. So for C, one of the important bloods in heart failure is a BMP, and we're also going to do an ECG, which is likely to be normal if it's just heart failure, but we might see some MI changes if that's what's triggered the heart failure. D, so don't ever forget glucose. So his blood glucose is 11 and his GCS is 15. His pupils are normal and reactive, so we're not too worried there. And E, is always important to check temperature, and that might help rule in and out some of our differentials as well. And Bob hasn't got a temperature. And because we are suspecting heart failure, the investigation that's the gold standard is going to be an echocardiogram to look at the function of his heart. So the management of acute heart failure, does anyone have any ideas what we might use for management? Yeah, so diuretics, really important. Yeah, furosemide, we're going to be giving that IV. So there's a bit of like an acronym for this one as well. So it's, oh my flipping God, sit up. So we're going to be giving him oxygen, which we already started 15 litres through a non-rebreathe mask. Morphine, because it can be quite painful, and that's also going to calm him down a bit and help his breathlessness. And with the morphine, we're going to be giving metoclopramide to stop him feeling sick. IV furosemide to get rid of all the fluids. GTN spray to open up all the vessels, and sit up. So position is really important in heart failure, because if they're lying down, the fluid's going to be covering a lot more area, whereas if we sit them up, then it will drain to the bottom, and hopefully the top of their lungs is still going to work. So I think that's the main management that, like in an OSCE situation, you'd talk through as the immediate management of heart failure. And there are some other ones as well that you can consider. So if their blood pressure is really low, if their heart's failing, then you can give inotropic agents such as adrenaline. you can do CPAP as well to help oxygenate them. And then there's some other ones I don't think we'd need to know as much detail, but it's good just to touch on, like ultrafiltration, which is basically getting rid of all the fluids, a bit like dialysis. And you can use mechanical pumps as well to help circulate the blood. And in the short term, it's worth considering whether it's worth stopping the beta blockers, as they reduce the contractility of the heart. So it might be exacerbating heart failure in the short term. Okay, longer term. So this is going to be done by the GP, and this is an emergency teaching, so we're only going to touch on this. There's quite a bit more to it, but basically, does anyone know the most important medications longer term in heart failure? Yeah, so beta blockers. Yeah, diuretics are really good for symptoms. So ACE inhibitors, beta blockers, aldosterone antagonists such as sprelaxolone are really good because they have been shown to improve mortality. Diuretics are really good for symptom control. And then there's a lot of other specialist drugs, which is less about the emergency management. Okay, next in line is a 37-year-old female. She's come in with chest pain for 4 days alongside some strange rashes. And on further questioning, the pain is sharp and central, and it's relieved by leaning forwards. So does anyone know what this could be? So there might be, yeah, pericarditis, that's perfect. So that's typical pain that's sharp and central and gets worse when lying down and relieving forwards. So other differentials could be esophagitis, because it's in kind of that upper chest area, costochondritis, inflammation in the ribs, ACS again, aortic dissection, pneumonia. So you'll notice a lot of them have similar kind of differentials. And this rash is a little bit of a rogue one, but it's more common in children. It can also be in adults. And if there was a foot as well, that is also going to affect the foot. Does anyone know what this rash might be caused by? Yeah. So it's hand, foot, and mouth, and it's caused by the Coxsackie virus, which is the most common cause of most common viral cause, sorry, of pericarditis. So unfortunately, this lady's been named Mrs. Coxsackie Isabel Smith by her keen scientist parents. So the pathophysiology of pericarditis is inflammation of the pericardium, so that the lining around the heart, and that's innervated by the phrenic nerve. So that's quite painful. And so the most common causes, 90%, are idiopathic and then viral, with Coxsackie virus being the most common. And then there's some more weird and wonderful causes. Some of them we already talked about. So post-MI and Dressler syndrome, and other ones such as TB, malignancy, hypothyroidism. I think if you just remember a couple, then that's probably all you'd need to know. So someone's kindly done an ECG for you of this lady. And does anyone want to tell me the most striking abnormality in this ECG? Yeah, so we've got widespread ST elevation across loads of leads. So we can see it here in 1, 2, a little bit in 3, AVF, V2, V3, V4, V5, C6. So this would be very abnormal for an MI. And another thing you notice is it's what we call saddle shaped. So if you look, it kind of dips down in the middle, then rises up again. And you might also notice some PR depression, which is actually the most specific change for pericarditis, although you're more likely to be able to see the global ST elevation. And the gold standard investigation is a transthoracic echo in these patients. So how are we going to help her? Luckily for her, is hopefully self-resolving. So we're going to be treating the underlying cause if we know what's caused it, giving a combination of NSAIDs and colchicine, and then just managing her symptoms as they come. But unfortunately, in this case, she deteriorates and she's now short of breath and her heart is racing. And if you look at her neck, you notice a pulsating high in her neck, or like a kind of fluttering, which, as you probably guessed, is an elevated JVP. So does anyone have any ideas what might have happened and what might have the pericarditis has descended to? So we've got two kind of options here. We have constrictive pericarditis and cardiac tamponade. So we're going to be comparing these two and looking at some of the differences. So tamponade, a large range of things such as trauma, and it's basically when there's fluid around the heart in the sac and it's stopping the heart from constricting properly. And constrictive pericarditis is one of the complications of pericarditis, and that's when the pericardial sac has become kind of fibrosed, and therefore that's also constricting the pumping action of the heart. So these two can present quite similarly, so it's important to know a few differences between them. So one of the differences is pulsus paradoxus, which is basically the fall of blood pressure of more than 10 on inspiration. So that's present in cardiac tamponade. Looking at the echo for cardiac tamponade, there'd be an effusion, so you'd see the fluid around the heart, and because of the fluid, you'd get compression of the right atrium, right ventricle. And looking at the JVP wave, I think this is very much exam knowledge, but there's an absent Y wave in cardiac tamponade. It's a question past medicine loves, so I thought I'd include it, and I've included a picture of the JVP wave on the next slide, so we'll go over that then. And the treatment is urgent pericardiocentesis, so you're basically sticking a needle into the pericardium to drain the fluid, and that's what's going to resolve her symptoms. So constrictive pericarditis is similar, but the pulsus paradoxus is absent, so you're not going to get that fall in blood pressure when she breathes in. You're not going to find an effusion on echo or MRI. But on MRI, you might see pericardial thickening, and on chest X-ray, this shows up as calcification. So that's calcification of the pericardium. On the JVP, the X and the Y waves are present, and the treatment is pericardial stripping. So you basically want to release the pressure on the heart by taking away a bit of the pericardium. And so this is the waveform of the JVP. So you can see the X and the Y, and the X is absent in tamponade, but it's present in constrictive pericarditis. So don't know if that will ever come up, but if it does, there you go. Okay, to the end, this is our final patient of the evening, Shaggy, who is a very tall patient with long fingers, and he presents with a tearing pain radiating to his back. So that might raise some red flags for some people. Yeah, so aortic dissection, and yes, Laura, yeah, he's likely got Marfan's from the description of him. So aortic dissection is a tear in the truna intima of the aorta, which leads to blood flowing into this false lumen and blocking the blood flow through the artery. So looking at Shaggy, we've read one of the risk factors is Marfan's, but the most important risk factor is actually hypertension. And other risk factors include trauma, bicuspid aortic valve, collagen disorders, so that's Marfan's and Ehlers-Danlos loss, Turner's and Noonan syndrome, which are slightly more rogue, pregnancy, and syphilis. So when we look at Shaggy, we've already talked about his chest pain, which is quite typical normally, starting in the center, tearing sensation towards his back. And if we do his blood pressure, what might we find if we do it on both arms separately? Oh, yeah, so we might find that there's a difference in the systolic blood pressure between his two arms. And when we take his pulse, then we might find there's an absent pulse, so that could be his femoral, his brachial, his carotids, they might be weak or absent, depending on where the tear is. So there's some ways you can classify aortic dissection. So there's two types of classification. There's a Stanford classification, which divides them into type A and type B, type A being more common with 2/3. And does anyone know what type A is? So I've highlighted the A because it helps you, because it stands for ascending, that's right, ascending aorta. So that would be the bit leading up to the aortic arch. And then type B is the descending aorta. And then there's also the DeBakey classification. It's a bit confusing to have two types of classifications, but these three pictures along the bottom show the three DeBakey classifications. So in type 1, it originates in the ascending aorta and goes all the way to the aortic arch and can go right the way down distally. Type 2 is just in the ascending aorta and is confirmed to the ascending aorta. And type 3 is in the descending aorta, and it can go proximally, but it normally extends distally down. And finally, oh, no, sorry, there's one more slide after this. So these are some of the different imagings of aortic dissection. So we have a chest X-ray, a CT coronary angiogram, which is the gold standard, and a transesophageal echo, which is particularly good if the patient's acutely unwell and you can't do a chest X-ray or CT because they take a bit longer. You can just do a bedside transesophageal echo, and that's useful. So in the chest X-ray, the most obvious thing we can see is this widened mediasternum. So you can see it's a lot longer across here than we'd expect, and that's typical of aortic dissection. In this CT, we can see this false lumen on the right, and that's in the ascending aorta. So that's it could be a likely type A. Where's my arrow? And then finally, I won't even kind of pretend to be able to understand echoes, but you can see that someone's kindly labeled that there's another flap here showing the false lumen. So that's how you could tell in an echo. Okay, so treatment and complications finally. So for type A, does anyone know what the treatment is? So it's surgery, yeah, urgent surgery. Before surgery, it's important to control the blood pressure to a systolic of about 100 to 120, just to prevent progression. And type B, does anyone have any idea what the management might be? Yeah, so it's often conservative medical management. So bed rest, and you can IV labetalol to prevent progression by reducing the blood pressure. And there is some thought that keyhole surgery might also be good for type B, but I think at the moment, normal treatment would just be conservative medical treatment. The complications depend on which part of the aorta is affected. So if it's the ascending aorta, then you're likely to get problems around the heart, so aortic regurg and an MI is often quite common. And then if it's descending aorta, then that's when you'd have the unequal arm pulses and blood pressure. And you can also have a stroke and renal failure because those parts are likely to be poorly perfused. So there's some of the earlier complications. And yeah, sorry for the few problems along that, but we got through it. I hope that was useful. Sorry I couldn't answer all the questions as we went. I didn't want to slow it down for everyone. There is a quick Kahoot quiz if people are keen to do that, and you'll get the PowerPoint if you do the feedback form, which would be really great. And another, just a bit of a disclaimer, all the resources, or most of them, were from Past Medicine and Bite Medicine. And for everyone revising their finals, I really recommend Past Medicine, Bite Medicine. I think I credit them with my degree, really. I'll just double check the Kahoot will load, and then if people are keen, it's just a quick 10-question Kahoot.